Wonderful. Well, welcome everyone to Race and Healthcare. This is our second episode, and today we'll be talking about racial bias and pain management. As you likely know, here at the University of Michigan, we have a truly nationally outstanding pain management team, and one of those members is our own Dr. Michael Smith, and we are thrilled that he is joining us today. So, Dr. Smith, thank you so much.
Thank you. Appreciate being here.
Wonderful. So there's been a good amount of at least academic and healthcare attention paid to this topic. And so can we just talk about where is this coming from? Where's the bias coming from? And is it being taught in schools? Is it being untaught in schools? And I'll just turn that over to you.
Yeah, I think that, let's think of a scenario first that we can keep in our minds while we're doing all this, right? So patient shows up to the emergency department in pain. Pain is not managed. Patient is sent home. Patient comes back to the emergency department still in pain. That gets framed very differently by patient, right? And so is that patient seeking drugs, or is that patient not telling the whole story? And I think one of the most difficult parts about this for pain is that pain is subjective. And that's really hard for people to understand. Everybody in healthcare, particularly pharmacists, want everything to be, for lack of a better phrase, black and white. We don't like living in the gray, and pain is gray. And we live in the gray and pain. And so there was actually a survey, and I think that started to uncover a lot of this. It was done years ago that it was a two-part survey. The first part was of just lay people with no medical training background. And it was to explore misconceptions in pain management and how we feel pain. And a lot of the participants stated things like African Americans have thicker skin. They don't feel pain the way that white patients do. And so that what they did was they took that framework and then they took it into those that had at least some degree of medical training, and those were primarily medical students. And the frequency of those responses was less, but it was still there and still pretty pervasive that these thoughts are there. And so, I think it comes from everyone's background, but that's the part of this that to me is really interesting, is because that's where pain comes from. Pain is actually a lived and learned experience. It's not something that we have within our bodies. It's something that our body learns over a period of time. And it's not just a physical thing. People can be in pain because of their emotions. They could be in pain because of their stress or because of anxiety or depression. And pain comes from all of those places, but it also comes from our biology. It comes up from our upbringing and what experiences we have. Trauma can play a big role in pain. And so that's what makes pain so different and so gray for everybody, is because every person has their own unique experience. And when they express pain, there was a new definition published about a year ago by the International Association for the Study of Pain. And that definition says, it has a bunch of sub-bullets, but one of the sub-bullets says that patients' reports of pain should be believed and accepted as is. It doesn't say anything about, race, color, creed, anything. It just says you need to believe the person in front of you. You need to try to figure out why that person is experiencing pain and give them the best treatment that they need for that pain, whatever that pain may be.
Mm-hmm. That is like enough for the entire episode right there. This concept, I know I have thought of pain as sort of just biological, something that my body is experiencing rather than sort of something that my body is doing. And in the sense of the mental contribution to it that you shared and the cultural contribution to it that you shared as well. I'm going to kind of veer a little and ask, would there be benefit for the average person to understand that information, that pain has these multiple rivers of input?
Yeah, and so I think one of the fastest growing field within pain itself is pain psychology. And the reason for that is we have learned pain. We need to unlearn that pain. And
Mhm.
not that your pain will ever go away, but it's more that you're understanding where your pain is coming from and how you
Yes.
can better manage it. Because, the normal way that we process pain, the center in our brain that can modulate it is also the center that deals with mood and emotions and sleep. And so oftentimes what we see is that that's all commingled, and patients don't understand that until they're explained that, did you notice in the last week that you weren't sleeping and your pain got worse? Oh yeah, I did. Well,
Mm.
was your anxiety worse too? Oh yeah, it really was. I didn't notice that before. And so these things all interplay because they've been learned and lived together, and you need to
Right.
kind of unpack a lot of that. And so um, in my practice, I spend a great deal of time with my chronic pain patients, helping them first understand how pain actually happens. And then when they're presenting with other issues, helping them understand, well, yeah, of course, when your anxiety is up, your pain is up. That's
Mhm.
normal. We would expect that, which means that when we're treating your pain, we can't just be treating your pain. We also have to be treating everything that's kind of underlying that. And so patients need to understand that, because um, they'll never truly get past their pain. Like, I could give everybody in the world a pain score of a 0 just by sedating them with way too much drug,
Right.
but that's not how anybody wants to live. But
Right.
you can't get them to where they want to live if they're not understanding all these contributing factors.
So, you are a specialist on pain management. You've had wonderful additional training than just, earning your PharmD degree. And in comparing that to sort of say what a medical doctor sort of gets as, training to be an MD who's not also being trained in pain management, what sorts of things should they be asking their patients, discussing with their patients? I come in, I've had this backache for 2 weeks. Ibuprofen just isn't cutting it. I'd like something stronger for my pain. What should my, say, general practitioner be discussing with me to get at these points that you're sharing?
First and most important, I think we often in pharmacy in particular overlook it, is our social history.
Mm.
So, what are all the accompanying factors that are there? What is your support network like? Because
Mhm.
oftentimes we find that patients that have chronic pain have really poor social systems, and we can't deal with their pain if we're not also helping their social system.
Right.
Um, and we also find that a good portion of pain, particularly in our younger patients as they grow up, comes from a place of trauma,
Okay.
whether that trauma is abuse or neglect or a car accident. That
Mhm.
trauma then rewires their brain, and they get into what's called, and this is a little detailed, but it's called chronic overlapping pain conditions, where you get one, but then you just keep getting other pain
Yes.
conditions because
Yes.
you've already gotten one. And so you're already exposed to it, you're already at higher risk of it. So going as far back to the first time that they felt pain as that they remember,
Mhm.
that's kind of within this course, like, oh, my back hurts. When did you notice that your back first started hurting? Oh, it was 2 years ago. Was there any preceding events to that? And so, because sometimes we have people that have pain that there's no traumatic event to it. And
Right.
that's really a big clue for us to figure it out, because there's what I'll call anatomic pain. So pain
Okay.
coming from a part of our body.
Right.
And then there's other pain called central pain that's coming from within our central nervous system, and they're treated very differently. But if you're not getting back to that detail, you
Right.
can't get the right drug.
Right.
And in fact, things like opioids make some of that pain worse. And so that you're already picking the wrong drug because you didn't go back far enough. So I think a lot of it's really about getting a thorough social history and timeline of events. And that timeline should include things like medications, but also doses of those medications. So we often say, oh, well, Tylenol didn't work for me. And I go, well, how much Tylenol did you use? And it's like,
Right.
well, I used 500 milligrams. And I can say, well, that's about half the dose that I need you to use before we can say it didn't work.
Right.
Um, but people aren't getting the level of detail. I think the kind of key is get back into their social history and put together a timeline, and then add into that timeline of other events that happen during that course, because it's not always just one event and it's like, oh, I had pain from 15 years ago. It's I hurt my back 15 years ago, 10 years ago I hurt my knee. Well, that's related because you changed your posture. And then it's, well, now I have neck pain. Well, of course you have neck pain. And so kind of parsing through that is what I see in the specialty world missing from the primary world.
Awesome. Thank you. This is really informative. I'm enjoying this conversation. So let's kind of hit some of the foundational components for this conversation. And the first is there a difference in pain tolerance based upon race?
There is and there isn't. That's kind of a packed question. So I'll give you some of the pieces of data that we know, and then I'll kind of unpack it to what we should be doing. So African Americans actually have lower pain thresholds for certain types of pain, like cold or ischemic disease. They tend to feel pain at a lower point than their non-African American counterparts. On the flip side, redheads, when I had hair, they have higher pain thresholds, but they're more sensitive to drugs. But that's a population level look at these things. And so when person is in front of me, I honestly don't really care. I want to know what their experience is because, when we go back to that definition, it's lived and learned, and it's coming from that person, and not every person has the same experience, regardless of whether you're African American or not. It's you're feeling pain. Okay, where's that pain coming from, and how am I going to better manage it? So to a degree, we have found on population level studies that everybody has different tolerances of pain, but that's the really difficult part of pain. Like a 4 to me may not be a 4 to somebody else, which may not be it could be a 10 to somebody else, or it could be a 2. It's understanding we want to put those numbers on it because we have to put numbers on everything, but it's more about getting at, well, how is this affecting your life? Like, you're telling me it's a 4, but you're not doing anything. So how do I get you back to functioning and doing what you want? So some of the things we do to get away from that kind of targeted question of, does everybody have different pain tolerances? Ask questions along the lines of mood and function.
Okay.
Because I have chronic pain patients that, like I have one woman as an example who has no teeth. She's had all of her teeth extracted. She has chronic pancreatitis. Her pain score is always a 10 because it's always there. It's all day long. She has multiple sources, but her mood and her function are great. Like, she's the happiest lady that ever comes in. She uses her medications appropriately. She doesn't let that high pain score impact her daily life. That's what we want to focus on, not necessarily like, oh, my pain is a 10. Well, if your pain's a 10, what's it doing to the rest of your life? If it's doing bad things to the rest of your life, let's fix that. But if it's not doing bad things to the rest of your life, and I'm going to give you a drug for that, that's only setting you up for failure.
Right. Wonderful. I'd like to hear, what are some of the things that you've heard from other health professionals about pain management, and particularly sort of based on race, and even more specifically around African Americans, because I'm going to ease my way up to the sickle cell question.
Yeah. So I think that, again, go back to that scenario that I brought up in the beginning, right? And so that is where we initially set up everybody for failure, right? So you're either coming in and not getting the drugs that you think you need, whether you need them, and you're either going to be labeled a drug seeker, or you could come in, get the drugs you don't need, and then get addicted to them. And then there's that kind of window in the middle, like you come in, you're appropriately treated, you leave. And that window in the middle is very small. But, I think it's the reality does not match the perception, right? So there is, has always been this thought that there are these disparities in care where African Americans present largely as drug seekers, and that's what they're being labeled as. There was a study that was done. It was a retrospective study, and they looked at about 200 patients over a year's period that came to an emergency department with one of, I think, about 10 classical signs of drug-seeking behavior to see how often these patients presented, what were they presenting with, what was done for them. The largest proportion of those patients were actually white. They made up about 70% of them. African Americans in that population only made up about 10 to 15%, if I'm recalling the numbers right. And then the other populations kind of filled in the rest about that, right? And so in terms of who we're seeing regularly, we're not seeing African Americans as the larger proportion of the population with those kind of classic drug-seeking behaviors. But I think they're often thought about that way. And I think a lot of that has been done by the medical system and how we have been pushed to manage pain over probably the last 30 years. At one point, pain was said that this is now the fifth vital sign. Well, pain is not a vital sign, and we shouldn't be treating it like a vital sign. But it's also been in our culture here in the States, where we all live in this world of instant gratification, right? And so everybody's normal experience of pain is probably headache, right? So I have a headache, I take some Motrin, my headache goes away. That's not how all pain is, but that's our experience of it. That's how everybody experiences. So I have pain, give me something, it goes away. And so we've put that on people, and then we fueled it with opioids, and we've made it worse for everybody, and particularly African American community. And on the flip side of that, right, so we give people drugs, and then they get addicted, and then we need to get them into opioid use disorder treatment. And on the other end of that, Black patients, in comparison to white patients, are about 1/5 as less likely to get offered opioid use disorder treatment, right? So you're not giving, well, like we're setting up the cycle. You're not giving them drugs they may need. You then call them a drug seeker. Well, then they need to go treat their pain regardless of where their pain is coming from. Then they get addicted, and then you're not treating the addiction. And so it's like, well, what do you think is going to happen? They're going to come back because they're still going to have pain of whatever it is. And it's this cycle that we have a hard time getting patients out of.
And let's kind of stay there for me, because you made a couple of points that I really want to explore a little more deeply. Let's stay about the cycle. What are healthcare providers what do they need to know or be paying attention to in trying to break the cycle, intervene in the cycle?
I think there's two things. One, I think we need to get out of our reflex of pain drug, and do pain, what's going to work best for that pain. And two, get back at kind of what I talked about earlier of what's underlying that pain, right? Is this person coming here because they broke their arm? Well, that's pretty clear. Or is this person coming here because they had a family member die? They have chronic pain, their pain flared. This is not pain that we need to treat with drugs. This is pain where, it's the tincture of time and somebody's sitting and listening to them. And so I think we need to get out of that reflexive environment of everybody's got to get a drug for pain, because it's not really how pain should be managed. Opioids originally were indicated for acute pain, and now we're just using them all the time. And we're trying to get away from that. And places like the emergency department here are doing many more non-pharmacologic things than they have ever been. The hard part of that is no one wants to pay for it. Like insurance companies pay very little for non-pharmacologic approaches to pain.
So then that just further complicates things, because how can I get you any kind of treatment? Your insurance isn't going to pay for it. But if I give you this opioid, you'll probably feel better or have less pain, or it's my best shot, and your insurance is going to pay for it.
Yep, exactly. And so we're not being helped by kind of any side of this. And so it's a matter of, again, trying to also then give patients resources that they don't need any money for. And so one of the chronic pain physicians here put together this giant packet of things that he'll send to certain patients for them to kind of unpack and learn their own pain, because not everybody's insurance is going to cover a pain psychologist. And we just started a non-pharmacologic clinic within our pain clinic, but not everybody's insurance is going to cover that. And so how do you get resource the person in front of you? Sometimes that is just being creative. Sometimes it is teaching them their own little exercises that they can do. Sometimes it's calling insurance companies and fighting with them for a while.
Right, right. The second point you made earlier was in talking about patients who show up who really are exhibiting drug seeking behaviors. The majority of them are white. And I'm wondering, are there thoughts about or studies indicating a role for implicit bias, right? Implicit bias can go either way for a patient or sort
Mhm.
of against a patient. That indicates physician healthcare provider bias of, oh, it's a white person, they probably really have pain, and let me give them this drug for
I haven't seen that. What I've seen that's kind of related is that white patients are less afraid of addiction than their African American counterparts are. And I think that that drives a lot of this. I think the other thing that drives it, not that implicit bias isn't there, I just have not seen any studies on it, is how these things are being articulated. And that probably underlies some implicit bias of this person in front of me is highly educated and spoken well and can clear. I'll tell you one thing, they're the biggest pains for me. Like I have patients that are physicians or have been physicians, and regardless of what they are, they're just the worst because they just want to keep talking and trying to convince you that what they're telling you in terms of all these things. And the highly educated people are frankly just much more difficult to deal with because they want to try to convince you back that what you're telling them is wrong. And it's like, well, I'm not wrong in the information that I'm giving you. I'm just telling you this drug doesn't work for the way you think it may work. And so I do think that there's probably that probably underlies a lot of it. But I have not seen any studies specific to pain management in that. But I'm sure that somebody hopefully is doing that.
Yes, I don't know either, but I think I'll be Googling that after our
Yeah.
session today. I wanted to talk also about patients with sickle cell,
Mhm.
primarily are African American, and the frequency that they are being labeled as drug seeking patients. And so maybe if you could kind of an overall of managing pain for people who have sickle cell and then medical intervention and how things kind of play out.
Yeah, so sickle cell is a young person's disease, right? And so it tends to be in patients that are prepubescent. The ones that get really bad pain are prepubescent, and right as they start going through puberty gets really, really bad. And then sometimes as they grow into an adult, that goes away, or they need a BMT, a bone marrow transplant. Um, the pain that they feel is very complicated. And that comes from kind of how sickle cell disease works, and in that, right, we're talking about sickling of red blood cells, and that causes problems when that sickled red blood cell gets into small spaces. And so the small spaces are our capillary beds. And so remember kind of where capillary beds are. They're going to be like the end of your fingers, they're going to be in your joints, they're going to be in your lungs. That's why those patients get acute chest. But that type of pain can present as I have pain all over my body. Well, yes, kind of course you do. But um, it tends to be very non-responsive to a lot of the drugs that we want to use, and a lot of the drugs that would be better aren't always great for the patient in terms of, so like NSAIDs as an example can cause problems with platelets. Well, we're already talking about a disease of the blood. And so it can be a kind of a complicated picture. The course for a lot of these kids generally is they'll get started with Tylenol and NSAIDs, and they'll be maxed out on that, or they're kind of getting injury to their kidneys because, we're trying to keep them off of opioids. But then outside of that, honestly, the next step really is opioids for a lot of these kids because of just how their pain works. We could give them other medications, but those medications aren't going to target the pain that they're experiencing. But then what they end up developing is they have this period where they have an acute pain episode, they get treated, they get discharged, but that pain never truly goes away. And so they end up developing chronic pain on top of that. And so in addition to kind of their sickle cell pain that they experience, they often have centralized pain because they've worn out their central nervous system from constant pain signals. And because they've done that now, fortunately or unfortunately, they've stepped into a world where we can use lots of other drugs because that'll help manage their central pain, but it won't help much with their sickle pain. They are, sickle cell disease pain is some of the most difficult to treat pain, not because of patient, just because pain that they experience tends to not be super responsive. And then that ends up making people, providers, particularly bedside nurses, uncomfortable because we tend to have to use higher and higher doses of things. And that patient is reporting high levels of pain. And again, it's trying to get our world to move away from these numbers. We have a patient actively now who's a pediatric patient, family history of sickle cell disease. Her brother had it. All sorts of problems treating him, not him, like he just had really tough pain to manage. She's younger, and she would always tell us her pain is a 10. It's always a 10, it's always a 10. She was 11. How can you get an 11-year-old to really understand that? So we stopped asking those pain scores and started asking things like, how was your day today? Was it better today or was it better yesterday? And seeing more trajectory. Did you participate in school today or did you not participate in school today, and getting at function? And then as she got more comfortable with kind of the questions, unfortunately, like our medical system and JCO doesn't align with like, oh, today's a better day, let's use less drug, or today's a worse day, let's use more.
Right.
It's all, oh, you have to put a number on it. We changed the scales for her where we said, okay, so what is your scale today? And her scale recently has been out of 20, but we don't put a limit on it and say, well, it's 20 out of 20 today. No, and before it was 40 out of 20. Well, we know that's a really bad day for this patient.
Right.
When she says it's a 20 or 25 out of 20, that's actually a pretty good day for her.
Mm-hmm.
But giving patient control over how they're telling their pain story also helps, but it conflicts a lot with how we manage pain because of a lot of our regulations are required to say, you need to put a number on this pain. Well, it's like, I don't want to put a number on it anymore. I just want to help this little girl sitting in front of me.
Right. No, I want to tell you that today she couldn't go to school and it was a worse day than yesterday. And there's no box to put that in. Wow.
There's nothing that I can check that says, okay, she needs more medication today because she said it was a worse day. But how do you put that on somebody? And to be honest with you, we have nonverbal pain scales, which a lot of people say we should use more and more of. But we're talking, in this case, a stoic little girl. She's not going to make a grimacing face when she's in pain. She's learned to deal with it and live with it. So she's not going to score on any of the nonverbal scores, but you can tell she's miserable when you're looking at her.
Mm-hmm. 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 So when a patient with sickle cell shows up in an emergency room, and maybe we need to take a step back and ask the question, why are they showing up in an emergency room in the first place instead of, say, contacting a primary care provider?
I think part of it has to do with kind of acuity and onset of that pain and how fast it can come on and how bad it can be. Part of it has to deal with response time from primary care providers who get 10 minutes to see patients. And pain patients are complicated regardless of where they come from. Some of my appointments are an hour and a half. Primary care providers don't have an hour and a half to sit there with their patients, unfortunately, because of how our billing system works. So, in our system, I think one of the things that we've done well, that I can actually say we've done well in the last couple of years, is put together a pain profile. So patients in their own time can go in and tell their pain story. That then gets loaded into our medical record, and anybody can update it at any point in time.
Yes.
but it's helpful because then they're not having to tell the same story to 30 different people that are asking the same questions. It's already there. You can review it. And one of the things that we've been trying to do here, and I'm sure they do it elsewhere, is we've been having, in particular, challenging cases, interdisciplinary meetings where we come up with plans, not just for when they get admitted, but what happens when they get to the emergency room, what happens when they're as an outpatient. And so we come up with a full-fledged plan for their continuum of care so that everybody knows what happens when this patient presents to the emergency department, or, you know, we have a lot of them now calling their hematologist because they're managing more of their pain, because they're doing more of their primary care at that point. But they haven't really been trained in pain management either at that point. So kind of finding those groups and coming up with plans so that the ball doesn't get dropped, because what ends up happening a lot of times for any patient in pain is if that ball gets dropped and they get behind in their pain management, it takes way too long to catch up versus being ahead of it. You can get ahead of somebody heading down south. You're going to do a lot better of a job than trying to pull them way back up because they've already gone down that bad path.
Right, for sure. I'd like to explore now a bit about what undertreating pain does for a patient. You just touched on some of that they can end up having more and more pain. And so now there's more work. But if you could talk a bit more broadly on that topic of undertreating pain.
So let me toss this back on you. Have you ever had a headache?
Yes.
Okay. Now imagine that headache has not gone away for weeks on end. What would your life be like? Would you be getting work done?
No,
You'd be mean.
Mean, cranky monster.
You wouldn't be sleeping. You probably wouldn't be eating. You'd be less productive at work. That's undertreating pain, right? Like that's it right there. And those are all the things, and there's many more that can happen, but you're basically putting something that people have a really hard time distracting themselves from because it's always there. And like even just a headache, like if it's throbbing at you all day long, how are you going to get anything done? How's the rest of your life going to go? So kind of like we talked about earlier, undertreating pain leads to sleep problems. It leads to mood problems. It leads to loss in work productivity. But then it also leads to other really poor outcomes of, if you're not going to treat my pain well, I'm going to go treat it. And that also leads to addiction, right? Because people are going to self-medicate if they're that desperate. And it may not be opioids. It could be alcohol. It could be marijuana. It could be anything at that point. We don't know, but you're propagating poor behavior because you're undertreating pain. You're putting in somebody in a desperate situation. What do you expect them to do?
Yes. And I think about people who don't have economic resources. They don't have a job that provides healthcare insurance. They don't have a job that, or the job they have requires such a high copay for a visit, or doesn't cover prescription drugs, that then being sort of driven towards pain management protocols, options, if you will, as well.
Yeah, and again, right, so it's so much harder to get that person back than it is to just treat them the right way up front.
Wonderful. So I want to open the floor now for questions. If you would like to put your question in the chat, you may do so, or if you would like to unmute yourself and ask your question, you can do so as well. Kelly Archer, who handles things behind the scenes for us, is monitoring the chat. But if someone would like to ask an actual question, feel free to unmute yourself and ask away. It's like teaching a class. You have to wait a couple minutes.
I can ask a question.
Please.
So with the research that's been conducted, there's, like, I've read like how medical students and residents and white people are still, like believing those myths regarding pain management and treatment for African Americans. what do you think like might be like the biggest attribute to that problem? Like lack of education or individual bias, or maybe even like blaming, I guess, kind of like the school of not educating the students? I don't know. I just
I I think it's probably multifactorial, but I think that a lot of it comes from the fact that we don't teach enough about pain. Um, Here in our pharmacy school, I think you all get about 8 hours of pain in total. Um, if you were to add up, so here's a piece of information that not many people know. There's more than 100 million Americans that have pain. That's more than cancer, diabetes, and heart disease combined. Um, in our curriculum, we spend more time on cancer, diabetes, and heart disease individually rather than combined relative to pain. I think it's really a matter of the fact that we lack the robust education about managing pain. I think that that's where it all comes from. Is people just don't know how to do it because no one's spending enough time when people are learning about it. And then by the time that not you, but anybody gets out into practice, right, they've already developed habits for how they're treating pain that come from people that are doing it. And so a common prescription in the hospital is oxycodone 5 milligrams. Why? Why is that like the thing that you're just reaching to? Well, it's because that was taught to you and that was taught to them. And it just comes down to the fact that we're not teaching enough about pain anywhere, not just here. This is common across medical schools, pharmacy schools, nursing schools. It's a lack of education.
Wow.
thank you.
Education and perspective, in the sense
Mm-hmm.
that if the field, healthcare as a whole, seems to need to better understand the role of pain in health, how many people struggle with it, and these multiple streams of input that contribute to a patient's pain.
Yeah, and here's another way to think about it. It's just a completely understaffed field. So if we were just to look at physicians and relative to trained in this, relative to the numbers of patients, each physician would have to have more than 25,000 patients to treat every patient that has pain. That's just not possible, right? So we don't have educational resources, which then bleeds into our healthcare resources, and then the people that are in the middle are as anybody with pain.
Hey,
Thank
Mike,
you.
it's
Go ahead.
Dan
Other
Hertz.
questions?
Yeah, can you hear me?
Yes.
Yep.
So can you talk a little bit more about how you would like to see the education around pain change? Because my perception, maybe I'm wrong about this, is that we think of it as a relatively simple topic because there aren't that many different classes of drugs and we don't really know how best to use them. So it seems like something that doesn't lend itself to great didactic training. Do you think this is something that everyone should have to do a rotation on, or do you have other ideas of how best to educate pharmacy students on pain?
Yeah, I think the one thing, right, is a lot of these drugs cross classes. And so like if you're talking specific class of drugs that only treat pain, you're really looking at opioids, right? Because everything else that we use for pain is somewhere else. Tylenol and fevers, NSAIDs and fevers, antidepressants, ketamine, all sorts of other drugs have all sorts of other indications. And so that tends to be our focus when we're teaching, is because this is the time that no one has really talked about opioids, because that's kind of what they do. I think the biggest thing that's really lacking is neuroanatomy and pain pharmacology, right? And so I don't think a rotation would make a lot of sense, but I think having students understand neuroanatomy, right? So if I have somebody who's telling me they have pain that starts in their shoulder and goes to their hand, that is very different than the pain that starts in their hand and goes to their shoulder, because their dermatomes in that path are very different based on even just which direction. And how you're going to treat that may be different, because it could be a bursa injury versus a peripheral injury. And so I think we don't spend, I don't know that we spend any time on it, but certainly not enough, if we even do, on neuroanatomy. And I think kind of the pain pharmacology comes into understanding how that pain is generating and then how those drugs are going to work, right? So just as an example, we talk about using gabapentin in diabetic peripheral neuropathy, but it should be talked about that we're using gabapentin because gabapentin is a calcium channel blocker that slows ectopic activity from a nerve injury. And we don't talk about it that way. I think within our education, we're talking about it differently. And so I think some of it's framing and some of it's kind of pulling that into one set rather than just focusing more on opioids or a certain type of pain.
Yeah, that's really fascinating. I didn't actually know any of that because I didn't learn it when I went through pharmacy school. I wonder a couple of years ago, there was a big push there to be a lot more funding around research around pain and and opioids and abuse and all those things. Did you see any funding go out to improve the education around these topics? Because it seems like it's not necessarily an issue of the drugs, it's an issue of the providers and what they're using and how they're using them, or at least partially.
That push really shifted very quickly from pain to addiction, and now a lot of the pain funding comes out of NIDA. The educational ones actually, interestingly, came out of drug companies. So Pfizer had a really big push to develop materials to educate. I think primarily because they make Lyrica, but nothing really has come out in the last probably 5 years that's changed how we're managing pain. I think we're educating on pain management. I think it's all been, again, pushed to more local resources. And then the other side of this is with the opioid epidemic, we've lost things that we didn't think about that we would lose. So the American Pain Society actually, during the whole Purdue Pharma being sued, got taken down as well. And so that was a huge society about education and developing guidelines that no longer exists because they got sued and couldn't take it anymore, even though they were kind of on the periphery of all of this. So like you said, funding kind of jumped up, but it's been it hasn't caught up on the clinical side and education. So before I got here, medical residents had 1 hour of pain management during their orientation period. Now they get a half a day. Despite the fact that they're more likely to see pain than any other condition. So we're getting there slowly, but nothing major's come out, Dan.
That is just fascinating. Thank you both for these excellent questions. We have time for one more.
I have just a question if nobody else does. Dr. Smith, you talked about the limitations that are kind of imposed by funding or by insurance on patients, especially like in your setting where you work with patients who have chronic pain. And when I was in the hospital, I actually took an acute pain management rotation. So I think that's like another thing that our curriculum doesn't really talk about acute pain at all, but that's just a side note. And I think like a lot of those patients had acute on chronic pain with their back pain. So it was like so many patients had like chronic back pain and shoulder pain, and then like they had some kind of surgical pain or whatever it was that was being treated acutely by an opioid or something. But that was like not even touching, and it was often oxycodone 5 milligrams, 4 to 6 hours. Like that's it's all very true, but that was like not even touching their back pain. And I think our team struggled a lot with trying to help them with that because their pain was still a 10 out of 10 no matter what we did. So I don't know if you have any like recommendations for that, or how. I don't know why I just turned this into a pharmacology question, but that's like something that I thought about a lot, and I don't think we really had an answer for those patients.
Yeah, so there's actually a huge study that came out of here. We have a chronic pain and fatigue research center, and they're studying duloxetine in chronic low back pain. I think that'll have some promising results, but drugs like duloxetine and TCAs tend to work for low back pain because as people have developed kind of a loss in their descending pain pathway. But the bigger thing for people, right, so this goes back to like find out what their pain is about. So what I tell people that have chronic low back pain is 1 pound of belly fat is 5 pounds of pressure on their low back. So if they can even lose just 5 pounds, they'd be losing 25 pounds of pressure on their back. And that's a lot of pressure. Like if you were to carry a school bag with 25 pounds worth of books in it, you can feel the difference. And so a lot of it is getting patients into exercise or physical therapy or anything that I'll say COVID has kind of ruined that for a lot of chronic pain patients. Gyms being closed has been a significant stressor for a lot of pain patients. So it really goes back to identifying source of pain and relieving them of it, right? And so this person that you're probably thinking of probably had back surgery where they had a fusion. And that's just a terrible idea for people with low back pain, because your vertebrae are all supposed to be able to go like this as you're moving. But if you fuse 2 of them, well, now it's going like this. And then that leads to pain up top and pain down below. And they're like, oh, we need to fuse these. And then you have people with fusions that are 4 or 5 levels deep and they're stiff as a board. Well, that's not going to make your pain any better. Flexibility makes pain better. Strength makes pain better for those types of patients.
Thank you.
Mm-hmm.
Thank you. All right, I'm going to ask one last question, and that is, do you have any recommendations for patients on how to advocate for themselves?
I think the best thing that they can do is use words to describe how their pain feels rather than putting on a number, and then say what that pain is causing in their life, right? So I always ask patients, if you were to describe your pain in your own words, what does it feel like? I don't really care what they say. I want to know what they're describing. So, excuse me, some people say it feels like a sword is going in my back and up and down. You know, I don't even need them to use the words I want them to use, like tingling and burning and shooting. I want them to have them have a little power over their pain. And then I want to know, what is that impacting in their daily life? So I think that that's the most important thing, that if you've got an elevator speech of your pain, it's use your own words to describe it and how's it impacting your function. That's much more important than any sort of number. And I think that also then avoids some of the concerns that people have. Oh, this person keeps coming in with a 10 out of 10 pain. Well, what if I told you I'm coming in because I can't get to work today because I'm bent in half? Right. Are you going to help me get to work today, or are you going to treat me because I've got a 10 out of 10 pain? I think people are more likely to shift their focus on function, and you're just going to get a better message across.
Awesome. Michael Smith, thank you so much. This has been really informative and very enjoyable. I really appreciate your time. I know you have a very busy schedule. And on behalf of everybody here today, thank you so much.
Thanks for having me. I appreciate it.
Awesome. So that concludes our second installment of Race and Healthcare. We'll be back again next month with a new speaker and a new topic. Thank you for coming or watching on video if you are, and have a great rest of your day. Bye-bye.